1, 2. Testing 1, 2, testing 1, 2. Ladies and gentlemen, testing 1, 2. Radio Alpha, Delta, Peter, John. Radio Alpha, Peter, Alpha, John. 1, 2. Testing 1, 2. Testing 1, 2. Ladies and gentlemen, Damas and Yella, welcome to the South African Medical Association. Testing 1, 2. Alpha, Investec, PSGL, Busamed, GEMS. Hi, brother. Thanks, man. Testing 1, 2. Ladies and gentlemen, testing 1, 2. Testing 1, 2. Ladies and gentlemen, Damas and Yera, testing 1, 2. South African Medical Association 2026 Health Summit. Innovate to elevate. Transforming healthcare together. SAMA is here for you, uniting doctors for the health of the nation. Testing 1, 2. SAMA is here for you, uniting. Ladies and gentlemen, you're kindly asked to please take your seats. Distinguished guests, delegates, partners, exhibitors, ladies and gentlemen, welcome to the first day of the South African Medical Association Health Summit 2026. Under this year's theme, Innovate to Elevate, we gather at a pivotal moment in healthcare, a time that calls for bold thinking, collaborative leadership, and transformative solutions that will shape the future of medicine and healthcare delivery in South Africa and beyond. It is both an honor and a privilege to welcome you as we come together to exchange ideas, inspire progress, and explore the innovations that will elevate patient care, professional excellence, and health systems for generations to come. We trust that over the course of this summit, you will enjoy insightful discussions, meaningful networking opportunities, and valuable engagements with industry leaders, healthcare professionals, researchers, and innovators. Before we officially commence with proceedings, please allow me to share a few important housekeeping announcements. Please note, this is a non-smoking venue. Smoking is permitted only in designated outdoor areas. Bathrooms are located outside the venue on the right-hand side, with the gentlemen's bathroom further on the first floor. For CPD accreditation purposes, kindly ensure that you enter and exit through the main entrance of the venue only. Please ensure that you have collected your goodie bags upon registration, and kindly ensure you have downloaded the app for further communications. Water and notepads are available at stations situated on either sides of the venue for your convenience. In the likely event of an emergency, please make your way to the nearest exit point and follow the guidance of the venue staff. We encourage all delegates to visit the exhibition areas situated opposite the registration desk, where our valued partners and exhibitors are showcasing exciting innovations and services. We also invite you to explore poster presentations on display in the exhibition hall throughout the summit. Kindly note, lunch will be served at the Ocean Breeze restaurant on the second floor. Delegates, however, with special dietary requirements are kindly requested to proceed to Lingela on the ground floor, where arrangements have been made accordingly. At this point, we would also like to extend our sincere gratitude to all sponsors, partners, and exhibitors for their invaluable support in making this summit possible. Your continued commitment to advancing healthcare innovations and excellence is deeply appreciated. Without further ado, ladies and gentlemen, please help me welcome on stage your Masters of Ceremony, Reginald, as well as Dr. Brett. Round of applause, please. Good morning, ladies and gentlemen. How's everybody doing? Yes, I am the face behind the voice that you guys have just heard. In case you were wondering, it was not God's voice talking upon you. It was literally just me. Welcome to today's summit. I trust that you guys have been enjoying yourself in the beautiful province of KZN. I am fortunately not alone. I'm joined by my esteemed colleague. I think I'm the cuter version of the two of us, if I really must say. The more handsome one. You know what they say, black don't crack, right? Brett?
Good morning, everyone. Sanbonani, Ninjani, welcome to KwaZulu-Natal. Yes.
Oh no, he's right in there.
Welcome to eThekwini. We want to once again welcome you to the South African Medical Association 2026 Health Summit, where we are aiming to innovate to elevate. And once again, thank you to all of our esteemed delegates, speakers, exhibitors, and sponsors. It's wonderful to be with you today. If I could ask that if you are seated at the back to just come up as we are moving, and let's fill up the front rows. We don't bite. Trust me, Mr. Masemola can confirm that. Please, if you're at the back, there's seating in the front. Let's try and fill up the front rows if you can. Thank you so much.
Thank you so much, ladies and gentlemen. Just maybe to do a run-through of the order of the day in which we will have. So basically, we are going to have the day structured in 3 sessions. The session number 1 is going to basically start us off, whereby we'll be doing our official welcomes and openings, whereby these will be done by the big bosses that are around. You know, whenever people of your caliber come together, protocol needs to be observed. The minister as well will also be joining us for those proceedings, whereby we will then have a panel discussion that will then usher us into our tea break. The second session will basically be joined after tea break, whereby we will then have another presentation that will basically be done by one of the departments, as well as our second panel discussion, which will guidely usher us into our lunch. After lunch, we will then conclude with our third session for the day, which will have a panel discussion, followed by a Q&A session, and then that will basically conclude our day. That is day 1, basically, in a nutshell. So, however, the reason why Brett is here, you're going to be seeing a lot of my face throughout the summit. He, on the other hand, is going to be somewhere. You're going to be doing something special, I believe, Brett.
Yes, Reginald. So if I could kindly let everyone know that if you're a speaker, you're going to meet me at our media booth. It's in between the Ahmed Al-Qadi Hospital and Discovery booths inside the foyer. And we are going to be conducting some interviews, and I will perform as your digital host or your AI host for this summit. Thank you.
So basically what that means is that we want to hear what everybody has to say. Unfortunately, not everybody is an extrovert like us who can share an opinion, and I know a few faces that always love to have a mic in their hands. But however, we want to know what you guys have to say. So basically, Brett will be conducting interviews with you guys behind the scenes to get to know what you guys have to say, basically. While basically, as SAMA, the reason why we are gathered here, we've had a beautiful 100 years of great healthcare and services that we have given. But we are saying, let's look into the future. What does the next 100 years look like for you specifically? How best can we equip you guys? And is the industry ready for all the digital transformations that are coming up? Clearly, you can see with AI, many of our jobs seem to be at risk, but luckily emceeing still requires a face, right? I can hope that I will still be with a job. Just maybe also for context, I'm the South African Medical Association legal advisor. So for many of the SAMA members in the room, whenever you guys have legal issues and you need somebody to assist you, I'm usually the guy that basically assists you with all of those, with HPCSA issues, complaints, assisting you guys with your practices, and basically ensuring that you guys are compliant across board, because that is who we are and what we stand for as an association. But Brett, maybe coming back to you, what kinds of conversations are you going to be having with our delegates throughout the day? What can they expect to hear from you throughout these conversations?
Thank you, Reginald, for the great question. We're here as doctors united for the health of the nation. That's why we are here. And I believe that we want to hear from you. If you're innovating within your organization or your practice or your company, we want to hear about it. And we want to hear about how we can collectively contribute to the development of healthcare in South Africa. We are gathered here in eThekwini municipality. KZN has the second largest population in South Africa, provincially, and I think it's very important that we understand the population that we are serving. How can we better manage these diseases and the burden for disease? So I think we want to hear about what you're doing, the innovations that you are applying to your organization, and how we can, as a unit, unite for the health of the nation. Yeah.
No, I mean, that is very good food for thought, if I must say. But one of the things that I think I have seen throughout many of these summits, conventions, indabas that you might want to call them, is that we tend to hear a lot of presentations, they tend to somewhat feel like lectures, if you can agree with me. And we don't really have a lot of time to really engage. And this is something that we'll really love to change throughout the summit. Our speakers have been prepped, they will do their presentations, but what is very important for us is that you are able to get an opportunity to engage with them. This will also include the minister once the minister gets here, and as well as all the other speakers. We want to hear your voice. This is an opportunity for us to speak to the people who we've always wanted to speak to. They are here. Once they are here and put their presentations, we will really move across the room and just basically hear what you guys have to say. With that being said, I really must say, I would like to just take two hands to start us off in terms of expectations. Expectation management is a very important thing, I think, for me. Let us start there. Throughout these 3 days, any expectations, what are you guys expecting to get? All of you took time away from your jobs, from your families. Some of you, this is a much needed rest from your families. So besides that, besides you being away and enjoying these 3 days, flying out of the country for all our delegates and having to go through customs, what does this weekend look like for you? Maybe let me start that conversation there. Any volunteers, before I pick on people, I just as a disclaimer, I love picking on people, just by the way. My advice to you, don't smile my way, I'm most probably going to pick at you. But let's start there. Expectation management. For these 3 days, let's take two hands. What are you guys expecting to get from this summit? Say that again. You expect to be fed. Okay. And get CPD points, right?
Okay.
Well, you expect to be fed. I think, have you had breakfast already? Let's start there. I think maybe we should check that off. Okay, we expect to be fed. What else are we expecting from this weekend?
Morning.
So you see the problem with doctors, you guys go from 0 to 100 very quickly. We went from wanting to be fed to a whole paragraph of, which you didn't hear. No, don't worry, I'll summarize it for you, don't stress, I'll summarize. So basically, in a nutshell, she's saying that we are here to identify the gaps that exist both within private and the public space, as well as come up with innovative ideas as to how can we move forward together as a collective. This is not a one-man show. Nobody exists as an island, if I can paraphrase what you were saying. And she's saying the conversations that we are going to have, she hopes that they are able to move us forward. Did I capture you correctly? Okay, thank you. You see, but I think I tried to summarize it because we're still waking up, right? So she just went on a whole thesis. Maybe let me take the last hand on expectation management. Going once.
Thank you so much, Doc. And it's great to be with you here today. Your two hosts, one works within SAMA as the legal advisor, as he said, if us as SAMA members get into trouble or we might have a complaint or we might have something where we think is not done correctly, SAMA is there for you. And I think as an unemployed doctor previously myself, I know that we do need to ask for help and find out what it is we would like to do and how we can contribute. And I do believe that this space, if you're looking for somebody to support you or fund your business, I believe there are people in this room that can help you with that. And I think if we are just clear of what value we are providing, in our organizations and in our business, I believe that we're going to find the right people that we're going to be here with. You know, we spend over 300 billion rands every year on public health. It's number 4 in our national fiscus behind servicing debt, social development, education. And as our previous speaker mentioned, what are we doing about district or rural health? We spend over 170 billion rands on rural health, which is more than urban. So why are we getting less outcome when we are spending more? I believe that is why we are all here. We need to contribute to all of these discussions that are being taken place in a meaningful and diplomatic way where we can be respectful to one another's views, and then we can also input our value proposition from our organization. So I would encourage all of the attendees today to, as Mr. Masemola said, just let's rise our expectations and let's all contribute to, you know, nation building through healthcare. The Medical Association, as Mr. Masemola said, has tens of thousands of members, but if you're not a member and you're a doctor here today, I can tell you that there is a lot of benefit for you joining. So if you're not already with the Medical Association, please consider joining. The South African Medical Association volunteers are around the room, and you can even come and speak to us. We will definitely help you on your journey to becoming a member. I believe there is value in coming together as a community so that we can solve these problems together.
Thank you so much. Well, I guess the scene has been set for the 3 days. 1, you guys want to be fed. 2, you guys want to make sure there are gaps. And 3, you all want to make sure you've got jobs in the future.
CPD.
CPD. Oh, there's also CPD points. Just by the way, regarding that, the minute you walk out of any room, kindly note that there's scanners at the door that will scan you out of this place. So remember, in order to qualify for any CPD point, you need to be in the venue for at least an hour for the point. So if you need to take a bathroom break, just try and time yourselves, right? Just to make sure you're not walking in and out and losing those valuable points. But ladies and gentlemen, I believe that just starts us off. Without wasting time, I would like us to please all rise. I do believe that delegates are not, they're not here yet. So the minister and the delegates, they're not here yet. So what that requires us to do is to continue this conversation that we are going to have. As a South African Medical Association for the past 100 years, I've been with SAMA for the past 5 years or so. One of the things that we are seeing is that we are seeing a lot of issues that are coming up whereby practitioners are feeling as though their voices are not heard as yet. They are feeling as though there are many issues within the industry or there's key stakeholders that you would like to engage. So maybe just quickly to find out, is there any particular stakeholder that you guys want to engage with that is on the program so that we can make sure you guys have enough time for that? Going once. The schemes are here, I can tell you that, so that is sorted out. Government officials are here, that is sorted out. Anybody else that you guys specifically want to engage with?
Hi, Adam Dodkins. We're one of the exhibitors. For me, there is a disjoint between rural health and regulation. And the speed at which patient care can get into the rural communities is significantly hindered by the regulation, and I think it could be a little bit in pharma as well, in terms of diagnostic care. And those stakeholders would, for us, I think, once suppliers have identified where we need to get to push through, to not push through, but to ensure that the regulation is met, I think your question on rural healthcare has improved significantly because there's such a delay in time from consult to care.
Thank you so much, brother, for the boldness, and I think you're doing a great job. As we said, I personally worked in Matibidi Hospital in Mpumalanga. It's 50 kilometers to the nearest supermarket, so it is very, very rural. And you'll see that those are the areas that, a little bit of extra resources could go a long way. And so I think that if we follow the processes, if you're in a medical device company, first of all, get registered with the Health Products Regulatory Authority. Make sure that your product is licensed and it's marketed ethically. And then the next step is to, go out there and start finding your ideal target market. And I believe in this meeting, there are institutions where there are practices, or there are hospitals, or there are organizations that are operating in those areas. So I do believe that you will find the right person here. And I believe we're just a few connections away, right, Mr. Masemola?
No, definitely.
We're just a few connections away from the person that we want to meet. So as Reginald has charged us, who do you actually want to meet at the summit? The minister's time is very short. I believe he is going back to Ekoli in a few hours. So you may not be able to see the minister, but I'm sure you may be able to see the Board of Healthcare Funders that are here, the Office of Healthcare Safety Standards that are here, the medical aids are here, I believe the banks are here, the mutual insurers are here. So there are a lot of people who you can talk to, so communicate, and I believe you'll be able to find the right people that you need to get connected to.
You will also note that we've got social media pages. There's an app. When you guys got your reminders, please make sure that you do download the app. That is where we will use for communication purposes. And once again, as mentioned, not all of us might have the opportunity to get the mic as well as to ask your questions. If you've got a burning question, please make sure you're able to put that on the app. If you have, however, any difficulties downloading the app, you can send us your questions or any inquiries on our social media pages. We will be using our LinkedIn page as the main form. You can find us at the South African Medical Association on LinkedIn. You can also follow me on LinkedIn as well. My name is Reginald Bokisana Masemola. So you can send me also inboxes whereby you've got any questions, anything that you might need to be asked, because luckily for me, I am mic'd already. So I get to basically ask the questions as and when we go. So yes, Brett, so in terms of you, where can we follow you? Where can people find the podcasts afterwards? How can we get in contact with you?
Thank you so much, Reginald. So you can have a look at our official South African Medical Association pages on Instagram, Facebook, and LinkedIn. You can follow me at Dr. Brett Lindell, that's DrBrettLyndall. But you'll see me there at the back. I'd love to have a chat with you, see what you're doing in your practice or your business or your organization, and let's see how we can all contribute to uniting doctors for the nation, for the health of the nation. Yeah.
Okay. So basically, that is the house rules that we are basically going we wanted to share with you guys. We've told you guys about the food, we've told you guys about the CPD points, we told you guys about the emergency exits, you guys know where to find us, you guys know where to follow us. So basically, we are now going to start us off with our official welcoming ceremony. This was basically an icebreaker to get to know you guys, just to get a feel of the room, just to hear a few voices. Yes, you are not all mic'd up. But I do believe that we are now going to be ready for the sessions that we are going to be following. So what I do request is that, ladies and gentlemen, let us please take a small intermission. I just want to double check that the minister is ready. And as soon as the minister and his delegations are on their way in, I will make an announcement and ask you guys to please rise. We will go into the national anthem as well as all that is necessary. I do believe that the minister is here and ready to be ushered in. So ladies and gentlemen, shall we rise and welcome the Minister of Health.
Colleagues, could we please be seated for a few more minutes? It seems there's some logistical issues there. Yeah. We can blame it on the N3. So please, someone tag Sanral. Yeah. Colleagues, if I could please just ask again, if you're seated at the back, just try and come and fill up the spaces in the front. You're going to get more out of it. You're going to see a bit clear. Yeah. Let's try and move in. And if you haven't been alerted of where the restrooms are, you can exit the main door, and on your right, you'll be able to see the ladies are on the bottom floor, and the gents are upstairs. Yeah. Yeah, if we can continue to just try and fill up the front there, colleagues. Thank you so much for your patience and grace, colleagues. May we please all rise to welcome the South African Minister of Health.
Ladies and gentlemen, let us remain standing for the national anthem of the Republic of South Africa. Thank you so much. You may sit down. Please let us welcome on stage performance by the Kola Brothers to start us off. A round of applause, please, ladies and gentlemen.
Usubenat, 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 usubenat. Amazing grace, amazing grace, how sweet the sound that saved a wretch like me. I once was lost, but now am found, was blind, but now I the sound that saved a wretch like me. I once was lost, but now am found. Wow, was blind, but now I see. 'Twas grace that taught my heart to fear, and grace my fears relieve. How precious did that grace appear, the hour I first believed. Amen. Amazing grace, how sweet the sound that saved a wretch like me. I once was lost, but now am found. Wow, was blind, but now I see. Hallelujah. Thank you. Thank you. Okay. Okay, good morning, everyone. We are the Kolwa brothers from Durban. Yeah, we are so pleased to be in front of you. Thank you very much. The song that we are going to perform is the song that talks about the beauty of Durban. In case you have never been here before, we're gonna just tell you about the beauty of this city of ours. Thank you. Just enjoy the song. Wolalela mfana ake uthule mfana kukhulunywa ngetheko 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 wolalela sikhuluma ngetheko wolalela sikhuluma ngetheko ake ulalele sikhuluma ngetheko ake ulalele sikhuluma ngetheko konani eThekwini kumnandi ngoba kunolwandle konani eThekwini iICC konani eThekwini iBavalio oseThekwini amahotela nekhetwe ikhona khonane eThekwini isikhumulo semikhumbi abanye bathi semkateni ukhona risho mfana eceleni kweKingspark basanda kusakhela ikasino thina eThekwini ukhona iKingshaka airport Moses Mabhida eThekwini ukhona umkhandlu omkhulu kunayo yonke iminyango masipala umongameli wokuqala mathupha umnyama waseSouth Africa uMandela wavotela phi eThekwini inhlangano yamazwe wonke ase-Afrika i-African Union yalontshwa phi yalontshwa eThekwini ngungquthela yomhlaba yokuqeda ubandlululo yabanjelwa phi eThekwini bonke abantu bafuna ukuze eThekwini mosekhona ufuna ukuze eThekwini okuphi neso ufuna ukuze eThekwini ophesheya kweziba ufuna ukuze eThekwini thina leThekwini sigibela igagasi thina leThekwini sesigibela igagasi woza eThekwini woza ke woza mama eThekwini sinakho konke okuhle woza mama eThekwini uzobona eThekwini Shaka Marine ikhona Shaka Marine ikhona Shaka Marine ikhona Inspire Castle sikhona Bridge City ikhona Mega City nayo ikhona woza wena uzobona woza wena uzajabula kwela kithi madoda akuve kumnandi kwela kithi akuve kumnandi kwela kithi lizwe akuve kumnandi kwela kithi profit akuve kumnandi woza wena uzobona woza wena uzajabula woza mama woza mama eThekwini sinakho konke mama helele mama woza wena uzobona woza wena uzajabula Thank you. Thank you. Thank you very much. Right. The third song that we decided to do for you is the song that you all know, I suppose. Imbube. Yeah, you are free to join us on stage if you feel like doing so. Okay. Wonansi imbube kwelakithi kum. Wonansi imbube South Africa. Wonansi imbube. Mbube. Imbube. 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 Wonansi imbube. 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 Wonansi imbube. Wonansi imbube. Wonansi imbube. 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 Wemawe. 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 In the jungle, almighty jungle, the lion sleeps tonight. Wemawe. 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 Wonansi imbube. 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 Imbube. Wonansi imbube. Wonansi imbube. Wonansi imbube. In the jungle, almighty jungle, the lion sleeps tonight. Thank you very much. Thank you. Thank you.
Ladies and gentlemen, let's give a round of applause to the Kolwa brothers. Ladies and gentlemen, Domus and Yera, Barena Lebahumahadi, please allow me to welcome on stage Chief Executive Officer of the South African Medical Association, Dr. Mzulungile Nodikita. Round of applause.
The Honorable Minister of Health in our country, Dr. Aaron Mtswaledi, the DDG from the Department of Digital Technologies and Communication, the President of the South African Medical Association, the Chairperson of the Board of the South African Medical Association, who is the current President of the Coalition of the African National Medical Associations, the leaders from our sister associations in the motherland, they will be introduced to you in due time, members of the board of the South African Medical Associations, the leaders of the association from across the country, the members of the association on whose behalf we lead this association, distinguished guests, our partners who shared in our vision as we were planning this summit. I want to thank you all for leaving your workstations this morning and grace us with your presence here. And it is my single honor and privilege to stand here in front of you today and not do what my boss is supposed to do, which is welcoming you, but to say the promises that we've made on all the ads that we sent out are today becoming a reality. We are in Durban, we've landed. I saw you've seen the flights. They all landed. We are here today. I want to thank you, and I want to say, asanteni sana to the delegate. Okay. So let me correct those who are saying asante sana. So when you are singular, when you are saying thank you in Kiswahili, you say asante sana. That's one. I was in Kenya. I learned that when you are talking to people, a number of people, you say asanteni sana. That's how you say it. We want to say welcome to South Africa, welcome to Durban, Molweni, Sanibona. I will be facilitating this first part of the summit. And ladies and gentlemen, it is my honor now to call on stage a colleague and a friend, the chairperson of the board, Dr. Mvuyisi Mzuku. Over to you, Chair.
Honorable Minister, Dr. Aaron Motsoaledi, the DDG from the office, from the department led by Minister Malatsi, the board of directors of SAMA, provincial leaders, local leaders, and also our leaders from the African continent. I've got brothers and sisters from Kenya, from Namibia, from Botswana, we'll be joined by others from Zim. We've got Zambia. You know, Dr. Piri is looking at me, how can you leave Zambia behind? Thank you so much for coming. I know it takes a lot leaving your families and leaving your practices or workplaces to come to South Africa to embrace this very important occasion. Thank you so much for coming. Let me also greet our colleagues from the industry, our sponsors, everybody who is here, the staff of SAMA. I can't forget the CEO. Otherwise, other things may not be done if I don't recognize my CEO. So thank you so much for all the work that you have done. Well, distinguished guests, esteemed colleagues, healthcare leaders, partners, innovators, members of the medical fraternity, ladies and gentlemen, I would want to say good morning and welcome to this summer summit in Durban. On behalf of the South African Medical Association, it is both an honor and a great privilege to stand before you today as we gather under the powerful and timely theme.
You are vertically challenged.
No, it doesn't help. You know, we always talk about this thing. It doesn't help because you can be tall and you're not leading. You know? So we lead by the head. This summit is more than a conference. It is more than a meeting of minds. It is a statement of intent. It is a recognition that healthcare in South Africa and across the African continent stands at a defining crossroads. We're living through a period of profound disruption, immense challenge, but also extraordinary possibility. The discussions we will have over the next few days about policy, technology, collaboration, investment, and leadership will help re-engineer the future of healthcare for generations to come. As healthcare professionals, we know that realities facing our systems are very complex. In South Africa, we continue to grapple with the dual burden of disease. We face rising rates of non-communicable diseases alongside persistent infectious diseases. We confront healthcare worker shortages, infrastructure challenges, unequal access to care, increasing medical legal pressures, and growing demands on already strained public health systems. Across the continent, many countries are facing similar realities. But despite these realities, Africa is not a continent without solutions. In fact, some of the most exciting and transformative healthcare innovations in the world are emerging from Africa itself. We're seeing telemedicine bridge distances that geography once made impossible. We're seeing digital health systems improve patient management and healthcare data collection. We're seeing artificial intelligence beginning to support diagnostics, coding, research, and healthcare administration. We're seeing mobile technologies connecting patients to healthcare services in communities where traditional infrastructure has long been inadequate. We're witnessing healthcare professionals and entrepreneurs developing solutions specifically designed for African realities. Homegrown innovation rooted in our own context, our own challenges, and our own strengths. And that is why the theme of this summit is so important. To innovate is not simply to adopt new technology. Innovation is about rethinking how we deliver healthcare. It is about asking difficult questions. How do we build healthcare systems that are sustainable? How do we create systems that are equitable and accessible? How do we ensure innovation benefits both urban centers and rural communities? How do we support healthcare workers who are exhausted, overburdened, and increasingly under pressure? And perhaps most importantly, how do we work together to create meaningful change? Because no single organization, no government department, no healthcare professional, and no private sector stakeholder can solve these challenges alone. Transformation requires partnership. It requires collaboration between public and private sectors, between policymakers and practitioners, between academia and industry, between established leaders and the next generation of healthcare professionals sitting in this room today. And that is precisely why gatherings like the Summer Health Summit matter. Events like these are essential because they create space, not only for conversations, but for connection. They bring together people who may never ordinarily sit around the same table: doctors, innovators, healthcare funders, researchers, coders, policymakers, students, entrepreneurs, regulators, and industry leaders. And when those voices come together, something very powerful happens. Ideas become action. Partners or partnerships are formed. Barriers begin to break down, solutions become scalable, and momentum is created. Too often conferences end when the final session closes. Important discussions are ahead, business cards are exchanged, photographs are taken, and then everyone returns to the institutions unchanged. But we cannot afford that approach anymore. Healthcare challenges are moving too quickly. Our systems are under too much pressure. This summit cannot simply be an event. It must be a catalyst for new thinking, a catalyst for courageous leadership, a catalyst for healthcare reform, a catalyst for investment into innovation, a catalyst for continental collaboration, and ultimately a catalyst for better healthcare outcomes for the people we serve. Because at the center of every healthcare discussion, every policy debate, every innovation strategy, and every technological advancement, there is one thing that matters most: the patient. The mother traveling long distances to access care, the child waiting for specialist treatment, the elderly patient navigating chronic illness, the overworked junior doctor trying to provide quality care in difficult conditions, the healthcare worker in rural clinic doing the best they can with limited resources. Innovation must serve them. Transformation must improve their experience, and healthcare systems must ultimately restore dignity, access, and hope. As SAMA, we remain committed to being a strong and a credible voice for healthcare professionals. We are also advocating for healthcare systems that truly serve the people of South Africa. We recognize that the future of healthcare cannot be shaped through resistance to change. It must be shaped through engagement with change. And that means embracing innovation responsibly and ethically. It means ensuring that digital transformation does not deepen inequality. It means preparing healthcare professionals for the future of medicine. It means creating policy environments that support innovation while protecting patient rights and professional standards. It means ensuring that Africa is not merely a consumer of global healthcare innovation, but a leader and a contributor to it. We must believe in African excellence. We must invest in African talent. We must strengthen African research, and we must create platforms where African healthcare solutions can thrive. This summit represents exactly that kind of platform. Over the coming days, we will engage with thought leaders, experts, and innovators from across sectors. We will challenge assumptions. We'll share ideas. We'll debate difficult issues. We'll explore emerging technologies, healthcare policy, medical coding, digital transformation, artificial intelligence, workforce development, and the future of healthcare delivery. But beyond presentations and panel discussions, I encourage every delegate here to engage intentionally, build relationships, exchange perspectives, ask difficult questions, seek collaboration opportunities, and most importantly, leave this summit committed to action. Because transformation does not happen in theory. It happens when ideas are implemented, when partnerships are sustained, when innovation reaches communities, when healthcare workers are empowered, and when leaders choose courage over comfort. To all our sponsors, our partners, exhibitors, our speakers, our organizers and delegates, thank you for believing in this important summit, for contributing to this collective vision for healthcare transformation. Your presence here demonstrates a shared understanding that the future of healthcare will not be built in silos. It will be built together. As we officially open this Summer Health Summit, let us embrace the responsibility before us. Let us innovate with purpose. Let us elevate healthcare with courage. And let us work together to create healthcare systems that are more equitable, more resilient, more compassionate, and more effective for all. The future of healthcare in South Africa and across Africa is not something that will simply happen to us. It's something that we must shape together. Thank you, and I wish you a meaningful and engaging and impactful summit. Thank you.
Thank you very much, Dr. Mzukwa. And I think for those welcoming words, we really appreciate your speech. I always say, Minister, this is our country. We have nowhere else to go. We have nowhere else to go. So the health system must work. It has to work for all South Africans. We really are not apologetic about that. And I think one of the reasons I love what I do is because the purpose of existence of SAMA talks to uniting doctors for the health of the nation. There is a bigger purpose. We're uniting medics in the country for the health of the nation. And it has to work, Minister. So I'm not going to waste any time. Just to explain the flow of things now, I'm going to call upon again the chair of the board to come and introduce the minister. The minister will deliver the keynote address, after which we will allow you to have an engagement, direct engagement with the minister. And then after that, we'll then move on to, I think we're supposed to go to a break, and then the MC will guide me from there. Over to you, Chair.
Thank you so much, CEO. Colleagues, without any further ado, I would like to introduce the Minister of Health in South Africa, Dr. Aaron Motsoaledi. What I do like about Dr. Motsoaledi, and I think we should say this publicly, is that, Minister, I think you keep that we have never heard your word, your name mentioned in anything that has to do with corruption. I think we like that. I think that's the biggest thing we like about you. So thank you so much, Minister. Let me not waste your time. Please come on stage.
Thank you very much, Program Director. The Chairperson of South African Medical Association, Dr. Mzugwa, the Director General of the Sister Department of Communications and Digital Technologies, here to represent the Minister, the CEO of SAMA, Dr. Nodikita, the leadership of South African Medical Association, and leadership from sister organizations from all over the continent who I met earlier on, distinguished guests, innovators and technology leaders, representatives from academia, organized labor, business, and civil society. Ladies and gentlemen, a very good morning. It is both a privilege and an honor to address the Summer Health Summit 2026 under the timely and important theme, Innovate to Elevate, Transforming Healthcare Together. I wish to remind you that while I'm coming here as a guest, I was born within this organization. So some of the things I know more than you, which happened during my time about this organization. So when I mention them, don't think I'm interfering. I was part and parcel. I was born from within the bowels of SAMA. This theme that is in front of you today on your screens is not just about embracing new technologies. It calls for a change in mindset from system maintenance to system transformation, from fragmented to integrated interventions, from reactive responses to proactive prevention strategies. Your summit convenes at the defining moment for healthcare systems, not only in South Africa, but globally. We, of course, recognize the threat brought about by the ever-present pandemics and disease outbreaks. A few weeks ago, the whole country and the world was panicking about hantavirus. Before we could even finish pronouncing the word hantavirus, we now have Ebola. And the whole world is again scared. I have even tried that on Monday, all ministers of health within SADC must meet and see how we are going to deal with this threat. And we are trying to come together and meet in Johannesburg because this Ebola, unlike in 2013, when it was in West Africa, it is now here in SADC, and we need to shine more. We recognize the threat brought by climate change, and we are aware that it's going to bring new diseases that we are not used to, some of which we have never seen in any textbook of medicine. We recognize, as has been said here already by the chairperson, the problems of workforce shortages, which unfortunately is not only in one country, it's around the world. We also notice the shortage of health commodities. But at the same time, we are aware that there's rapid advances in artificial intelligence, digital health technologies, predictive analytics, genomics, robotics, and automation that are fundamentally reshaping the future of healthcare delivery. I have just returned yesterday from the annual gathering of all ministers of health around the world, the World Health Assembly, which is held in May in Geneva every year. Now, all these challenges that you are going to discuss here in the next 3 days are on the agenda in Geneva. That conference is ending only tomorrow, but some of us had to leave before time. So some of the things on the agenda there, many of whom I've mentioned, are being discussed. But the main topic on every minister's mind in Geneva this week was the greatest challenge of dismantling the healthcare architect that has been coupled together inch by inch for the past 78 years. That is the multilateral system of healthcare, which you are all accustomed to, which has been built immediately after the Second World War, together with the United Nations, a system that has always been led by the World Health Organization, from which many of us in the medical fraternity takes our cue and our direction. This system has always informed us how we plan together, act together as distinct countries, but united by common purpose to secure health as a fundamental human right and to secure health security as a human imperative, not just an option. Now, that system is being dismantled by one man who regards himself as more powerful than the whole of humanity combined. So the main discussion item in Geneva is the building of a new global health architect. What is the new global health architect going to look like? What is it going to be? And how are we going to build it? Because we can't go back to where we were. Where we were doesn't exist. One man has dismantled it. It's gone. But we also can't stay where we are, because that doesn't constitute development. So where to? So in building and pursuing a new global health architect, innovation is going to be our guiding principle. But the question before us is not simply whether healthcare systems will innovate. That we have got no option. We have got no choice. We have got to innovate if we are to survive. But the question is whether innovation will be harnessed to deepen equity, strengthen solidarity, and ensure sustainability of the healthcare systems by expanding access in good quality healthcare for all. And all means exactly that. It means all, regardless of socioeconomic status. So when is this innovation going to reach everybody? Because I want to state here up front, innovation without access is actually a crime. Because what are you innovating for? For whom are you innovating if it can't help to transform humanity. I want to deal with a few topics, ladies and gentlemen, which I hear you are going to engage me. So I want to engage you even before you start. Because I do suspect I know some of the things you are going to engage me on. The first topic is the issue of universal health coverage. And the sovereignty of nations in their healthcare systems. The irony of this one man who is dismantling the system we are used to. The irony of it is that the system is dismantling on our continent actually constituted dependency. Because many of our healthcare systems on the continent are funded from one country. Yet we called ourselves sovereign nations. So we need to put up a system of universal health coverage to avoid handouts. There are, unfortunately, countries on our continent which up to 80% of their health budgets, not programs, budget for the whole health system, are funded by one man who has now decided enough is enough. So we need to do something about it. Forget about our battles, colleagues in South Africa, about NHI. Forget about the battles. That is what I call brutal tweets. It's going to solve itself. Because universal health coverage is going to happen in my lifetime, I can assure you. In my lifetime. Well, God has not yet told me how long I'm going to live. But I'm sure that universal health coverage is going to happen in my lifetime. Because the system that we are in is not going to be sustainable. All the signs are there. Now, unfortunately, in this battle, I've heard some, after last week, Constitutional Court ruling about the certificate of need. I had some celebrating that a pillar of NHI has been destroyed in that regard. It has fallen. I'm not sure why people believe that. The certificate of need, which the courts have rejected, and we accept that fully, is not a central pillar of universal health coverage. It can never be. If you want me to tip you, if there is anybody who's interested in bringing down a central pillar of universal health coverage, the central pillar is going to be primary health care. It's going to be primary health care, and it was discussed in Geneva. And what I like is that even civilized nations, those who used to believe they are rich enough to provide health care to everybody without even considering primary health care, are starting to change because it doesn't work. Many people believe when I say primary health care, I'm talking about sending people, everybody to clinics. That's not what primary health care means. Primary health care means prevention of diseases and promotion of health and putting less emphasis on curative health care. It means a system that recognizes GPs as a central pillar of the healthcare system at the beginning where it starts. Not the present system where everybody wakes up and just jump to the highest level of the healthcare system. That's what primary healthcare means. It is going to be the central pillar. The second pillar is equity in healthcare financing within countries. if these two pillars are vanquished by the courts, as some were celebrating, then I'll agree with them that the central pillars of NHI are gone. The issue of primary health care and equity in healthcare financing. So if you want to capitate the new system, go and decapitate those, not the certificate of need. Now, there are green shoots of primary health care in South Africa that are starting to show. And I'm just warning you that as we move together, we are going to push very hard everything in that direction. The first one I want to mention to you, colleagues, is the launch of Lena Kapava, not just as a new innovation. It is a great innovation, I'm sure you know, because trials have shown that Lenacapavir injection taken 2 times a year, every 6 months, guarantees young adolescent girls 100% protection from HIV, and men having sex with men, 96%. That's very high. But we are not using it just as that innovation. We are using it as a tool to eliminate HIV/AIDS as a public health threat by 2030. We have lived for 44 years with HIV. We must not get used to it, not only as doctors, but as the whole society. We must not get used to it as something that must live with us. We must get rid of it. And we are looking at this innovation as a tool in that direction. So we'll be launching it in South Africa on the 5th of June in Mpumalanga by the president of the country himself, because we want it to be at that level. We also have taken upon ourselves that we must start the process of eliminating TB after more than 200 years of its existence. So in South Africa, we took a decision that we must screen 5 million people annually for this disease. And how are we going to help that innovation again? There's a new innovation of digital X-rays machines that can be carried on one's back through the mountains and valleys of rural areas, and which does not necessarily need a qualified radiologist to analyze, because it is based on artificial intelligence as a new innovation. We want that innovation to reach the most rural parts, the far-flung forbidden places of our countries. And in South Africa, we have decided that we'll start that in July this year. You are aware that there is also a vaccine which is going to help us to vanquish this TB, not just digital X-rays where we'll see lesions and so what. There's also a vaccine that is undergoing 3rd phase clinical trials in 7 countries around the continent and in Asia. And we are happy that most of the trials are happening here in South Africa. We also are on the verge of starting a campaign to eliminate cervical cancer, at least by 2030, using another new innovations. In the same way that UNAIDS gave us a formula to eliminate HIV called 95-95-95. The World Health Organization has given us a formula called 90-70-90 to eliminate this dreadful cancer That is the second biggest killer of women, and that's very expensive to treat. The first 90 means 90% of all the young girls up to the age of 15 must get an HPV vaccine. We're just lucky in South Africa that we started long ago in 2014 when the HPV vaccine became available. And today, as I'm standing in front of you, we have vaccinated 6 million schoolgirls in public schools. We did not leave private schools because we hate private, as people like saying. We thought the parents there are well-to-do. But we are happy to announce that since the World Health Organization has declared that 1 dose of HPV vaccine is enough, we used to give 2 doses to 1 girl every year in February and October. Since the World Health Organization has declared that 1 dose is enough, we have taken a decision that will now visit even private schools when we start this 90, 70, 90. So 90% of all the school girls must have this vaccine coursing through their veins. The second, the 70, is that women between the ages of 35, up to age of 35, and again 45 years, must be screened using the new DNA-based technology, meaning we are moving away from pap smear. That's innovation. And we want it to reach every woman, regardless of their socioeconomic status. The last 90, which I don't want us to arrive at in full speed, is that all women who are stage 3 and stage 4 cancer need to be put under treatment. We all know what that is going to cost the country. And so we want to put emphasis on the 90 and the 70. We also are on course to put legislation in Parliament to vanquish the vagaries of smoking, like vaping and all these new methods of delivering nicotine, which is now a playground of school kids. We also have to control excessive alcohol intake. I told my cabinet when they issued the strategy on gender-based violence, I said, if you don't deal with alcohol, forget about that strategy. Because most of the gender-based violence is driven by alcohol, with the doctors coming to clean the mess from behind. The issue of HR policies. When we talk about innovation, colleagues, we are not just talking about something that is a sign of wisdom. It must also be a sign of bravery. Because when you are an innovator, you shouldn't be scared of making mistakes. Because only those who make mistakes can develop. If you are scared of making mistakes, then you don't act. You stay in one place. So some of the innovations might actually cause trouble, but you have got to face them head on. You have got to be prepared to fly where eagles dare. Because if you are afraid and you just want to fly low, you will remain that low. We have got some HR policies in our country that we need to look at, that unfortunately I know are going to cause us ructions in the country. But we have got no option, we need to look at them. I know there have already been clashes and warnings that there's going to be a rebellion, but we can't be scared to innovate because of that. 4 policies need to be looked at and looked at scientifically. Is the policy of RWAPs, which I know many of you are married to. Remunerative work outside the public service. I'm one of the longest serving ministers, if you don't know. I've been in government for 32 years now, the age of which many of you have just reached. I know where this thing started. Yes, in 1994, after Nelson Mandela became our president, Labour, led by COSATU, came to the state and complained that the public service doesn't pay as much as the private sector. So the public servants, not doctors, public servants need to be allowed to go out and augment their salaries outside the public service. At that time, the government agreed because it was true. I used to see professors of medicine leaving medical schools, going to look for a job as a chief director in the Department of Health, in various government departments, in this case, the Department of Health. And so the government agreed, and the principle of RWAPS was born, that yes, public servants, not doctors, public servants, can go and do remunerative work outside the public service at particular times. Now the problem is that RWAPS never grew significantly or substantially in other sectors. It grew among doctors. I still don't know the reason. But people, the word RWAPS now is associated with doctors, not any other public servants. And our nurses do what is called moonlighting. These principles go together. And don't think they've got no bearing on the healthcare system. They do. We do have evidence of students who are lacking trainers because the trainers are out in private doing RWAPs, but when they are employed by the state. I was once phoned by a manager of Mediclinic in Polokwane, that's my hometown. When the university, Sefako Makatu University, which used to call Medunsa, before there was a medical school in Limpopo, where medical students were sent to Mangweng Hospital. That's where the conjoined twins were separated a few months back. They were sent there and sent with lecturers to help them. The CEO phoned me and said, "Minister, I understand you have sent medical students here to learn in Limpopo, and we have sent lecturers to teach them and guide them." I said, yes. He said, when do they do that? I said, why are you asking that question? He said, because the lecturers we are talking about are here at Mediclinic doing operations every day. And I know it because I'm the one who gives them the theater time to do so. So I'm asking, when do they teach those students? These are important things that we need to look at if we have got to come up with new systems. Then we have got committed overtime, which has got ructions in provinces like Limpopo and Eastern Cape. We need to look at it scientifically. Then we have got rural allowance. Many of you don't know where it came from. Some of us who are old, very, very old, know that. The term rural allowance was a diplomatic term invented when our democracy came. It has been there for ages, and it was called territorial allowance. When in apartheid South Africa, a white person goes to work among black people, they say they've gone beyond territory, and so they need the territorial allowance. During my school days, I attended a school in Polokwane called Stotolwane, where most of the teachers there were white, 90%, and they were earning this territorial allowance. We used to call it tolerance fee. Now it has changed the name and called rural allowance, where we're supposed to reward those who work away from tar road, from TV, from electricity, from cleaning running water. Today, that money is earned by those who stay in town, simply because they drive 15 kilometers out of town to see rural people there. The Department of Education has overtaken us. They've done away with it. So please, I want SAMA to participate fully on that. Then, statutory bodies. Colleagues, you know that we have got the Health Professions Council of South Africa in our country. It's the moral authority of our profession. It's supposed to guide us. but you are aware it's not a secret, it's in trouble. SAMA was there when I called a meeting of all the associations, deans of medical school. We need to unbundle the Health Professions Council of South Africa and start from the scratch. It is not working the way it is. And I want you to be part and parcel of it. You might not know the history of how important these things are. It was in 1977 when one of the most eminent black leaders in our country, Steve Biko, was murdered by the security police, and doctors collaborated in that killing. Yes, doctors collaborated because they deliberately gave wrong information of how he died and what killed him. And they wrote it under oath. Yes, that was a plot on the profession. And what happened is that the world did not take it kindly. Some of our professionals were harassed overseas when they go to give lectures. How can doctors collaborate with the killing of patients? Because once that happens, then we cease to be members of this profession. They challenged us. Now, everybody was expecting your predecessor, Masa. Remember, we were called Masa before. Yes, SAMA came recently. So when I say I was a member of this organization, it's because we were members of Masa. And Masa did not move. And the question is, how can, because HPSA at that time, called Medical and Dental Association, never took action against the doctors who collaborated in the killing of Steve Biko. They never did. And the question is, how can the profession keep quiet when something like that happened? We broke away and formed NAMDA, National Medical and Dental Association, which we collapsed after democracy when SAMA was formed, because we thought SAMA would take the baton and not repeat what happened during the apartheid state. They must always teach their doctors to stand with the patient. So even when your profession is suffering in the manner in which the Health Professions Council is in trouble, we expect you to stand up as SAMA to make sure that we have got a Health Professions Council, or at least a regulatory body, because I don't know what we are going to call it. What I simply know is that what you have now has to be changed, and innovation is again needed. What professional body that controls us and that guides us, what is it going to be called? It's important. Section 59, Dr. Mzuku. Section 59, which was put up to avoid corruption in the medical scheme system, has now been utilized, but we believe wrongly so. Yes. Wrongly so, targeting specifically doctors who are not classified as white in South Africa. That we can't allow. I'm sure you are aware we met and agreed that we need to put up a judicial system where doctors who have been wronged must go and stand in front of a judge and a panel to give their side of the story, not the side of the story of those who believe money was stolen from them. So I still want you to participate fully in the Section 29 project. Encourage your members. Yeah, that's innovation. That's what it sometimes does to human beings if it goes wrong. Innovation sometimes does that. So we need to be very careful. Then I'm running out of time. You are aware that we did have a market inquiry. I was asking Dr. Mzuka because they informed me that yesterday you were having what they call a coding conference, coding systems. And I asked them whether they are aware that that is not complete without us as a country knowing how much each and every procedure costs. We don't know at the moment. For those who don't stay in South Africa, they may not understand. We don't know. Medical schemes decide what to pay you. If they don't want to pay you what they want, yes. Medical schemes decide what to pay you. The Council of Medical Schemes tried to protect patients. Why did medical schemes do so? Because they believe what was being charged. For instance, how much does a Caesar cost in South Africa? None of you know. It depends on who performed it and in what hospital. Should we go on like that? The Council of Medical Schemes tried to introduce something called, what is it called? Remind me these particular diseases for which medical aids are forced to pay. Yeah, prescribed minimum benefits. I don't know whether you are intimidating me. I'm starting to forget some terms. They came out, which is called prescribed minimum benefits. You know, as a profession, that's not where we should end. It's actually a scandal on our part, because none of the medical textbooks we have read talks about those things. Thus, diseases must be classified in terms of payment. It's not there. It's not there in medicine. When they show you a treatment for diabetes, they show you a treatment of diabetes. They don't say, if this person earns this much, this is the treatment. If this person is a DG, it doesn't say so, but we are practicing it. Yes, that ethically is wrong. We need to look at it. So we established a market inquiry, as you know, chaired by the former Chief Justice Ngobo, and people believe we have forgotten about it. The final report came in 2019. You all know what happened. It was shelved because of COVID-19. From there, after we started, immediately after COVID-19, especially in the new dispensation after 2024, we started, but we met quite a number of legal headwinds in terms of what law to follow, etc., because it involves 3 departments or 3 entities: the Department of Health, the Competition Commission, and the Council of Medical Schemes. We have now worked together. Very soon we'll be releasing regulations, which we want you to interact and do public hearings with, and interact and tell us what to do. The regulations will be giving a guide about the cost of various procedures in South Africa. It will match with your quoting system very well. So your quoting system is not really complete. It's a good job you have done. It leads us somewhere, but it won't be complete until we know what procedures cost. And we in the Department of Health will lead that process. Infrastructure, which you always tell us that no, there cannot be any NHI, we are not ready because we don't have infrastructure. We need to correct it, even though I don't believe we are not ready. We need to correct it. And so if you check the State of the Nation address, the president mentioned quite a number of new hospitals that need to be built in South Africa. These are not going to be ordinary hospitals, let me tell you. They are not going to be ordinary. They are going to have all the new innovations. They are going to be state-of-the-art. Starting with 3 academic hospitals, maybe at this juncture, because you are summer, and some of you may still be young not to know this history. Because we need to start correcting the injustices of the past. If you check all medical schools in South Africa that exist, that which have been built for our white compatriots, it was a medical school and an academic hospital built together. You can go to UCT, you'll find that. You can go to Tygerberg, you'll find that. You can go to Universitas, you can go to Charlotte Maxeke, Steve Biko, you'll find that. But in 1953, when the first black medical school built for Africans, Indians, and colored, in a white university called University of Natal, when they built that medical school, they call it Black Section. No hospital was ever built. We were given King Edward the 8th Hospital, now called Victoria Mqenge. It was just a small district hospital. No medical school was ever built. That was in 1953. 20 years later, we went up country to establish a medical school called Medunsa, Sefako Makgato Health Sciences University today. No hospital was built. They were given a hospital called Garangua, which is now called George Mukari. Garangua Hospital was a small district hospital built for a small settlement called Garangua outside Pretoria. Because if you know Pretoria, the townships there were Mamelodi, Atteridgeville. When they went up north, they started with Garangua. It was very small, so the hospital had to be small. It was never a teaching hospital. 15 years later, they waited and went to Mthatha in the former Transkei and put up Transkei Medical School, which you call Walter Sisulu. No hospital was built. And I have been fighting from 2014 that this injustice must be corrected. And of course, it wasn't. But I'm happy to announce that at long last, after so many years, we are correcting this injustice. These 3 teaching hospitals are going to be rebuilt, not with small amounts of money. The George Mukari Academic Hospital, we want it to be built for 8 billion rand and have everything, simply because it's biggest. The department, the Minister of Health has already announced a BFI, or budget facility for infrastructure, where we're going to bid. And the first bid window is in July. We're going to bid for these hospitals. The second bid window is in October, where we'll add 8 other hospitals, which we have already planned. And the rest will be community health centers. The issue of health information systems. This is very funny. Despite all the innovation that has taken place in technology, we still don't have a health information system in South Africa. We've got health information systems that is disparate, that don't talk to each other, that cannot trace a patient from one system to the other, where patients' histories are known from one GP to the other, one specialist to the other, public, private, clinic, hospital. That system is not there. By 2010, all the 9 provinces spent 4.5 billion rands to establish new health information system, but none was working for us. We put up a moratorium and went to the Center for Scientific and Industrial Research and say, please, design for us a South African-born healthcare information system, owned by South Africans, pay no license to everybody, but owned by us as a nation. It took 8 years for the Center for Scientific and Industrial Research to do that. It is now ready. We are busy piloting it. It will trace a patient from one system to the other. It will give history from one practitioner to the other. It will help us integrate health and public health, private and public healthcare system, that information system. I want to end up on a note that might not be comfortable for some, but it's the truth. When will I be happy that public service in our countries can serve everybody equally? I don't know whether you know that we are the only continent in the whole world. We are the only continent where when a head of state is sick, they must go to another continent to look for health care. All heads of states in Africa do that. When they are sick, they either go to China, they go to Russia, they go to Europe, they go to America. Show me any other head of state from any part of the world who has done that. It's only us here. What have we done? What wrong have we committed? Why should that be? And I'm happy I met a colleague from Namibia here. Namibia who's from Namibia? Congratulations to you. I was with your minister in Geneva. And on 2 occasions in different meetings, she was brooding how the president of Namibia, a woman, the first woman to head that country, has given direction that starting with herself to all the ministers and public servants, when they are sick, they must go where the masses are and be treated together with them. I'm itching for such a system. So Namibia is broken out from this curse of having to go to. And what frustrates me is that we're not as foolish as we think. Yes, I will give you 3 examples. At Steve Biko Academic Hospital, we have got New Mary, the nuclear medicine facility, run by Professor Sateche. It's world class. It's world class. It's the best in the continent, but world class. Since they started doing alpha targeting of prostate cancer cells in 2017, since that time, 50 of their patients came directly from Europe because of people who know Professor Sateche in Europe, because he has been receiving prizes there for innovation. Yes. So 50 patients came from Europe. Somewhere in the air, when they were coming for that treatment, somewhere in the air, they met our heads of states going to Europe to look for treatment. That's a very big irony. I know, because I've been with Professor Janabi, the new regional director of World Health Organization on the African region. He's a professor of cardiology. He told me how they built the best cardiothoracic cardiology center in Tanzania, his home country. Because Tanzania was spending 1 billion rand every year sending patients to India. And he said, he told the president, why can't we use this money here to establish our own cardiology unit? It is working now. And all the masses, even those who are not educated, who have got no titles, can utilize it. I know that Kenya has got one of the best renal transplant units. These things are not spoken about. How can they be when in Europe every day they see your leader there coming to treat flu? They believe we are a dark continent. So I'll only be happy the day we improve the public healthcare system such that our heads of states are treated with us here. Because I don't know, colleagues, whether you know what happened to me. In September last year, I went to do a cataract operation. I chose a public hospital under Chris Hani, which Panascon Hospital, which used to be the biggest hospital in the Southern Hemisphere. I chose St. John's Eye Hospital. And you saw it was all over the papers. It's a big story. I'm sure some people enjoyed it, but I did not necessarily enjoy. Why should it be a big story when I go to a hospital where people are being treated? Because a minister has gone to a, that hospital is doing 3,000 cataract operations every year. But when one minister goes there, it was a big story. The other stories, I read them and absorbed them. But one that killed me from inside was when a columnist wrote a long story praising me for even wearing the pyjama that other patients wear. Because, yes, that I even wore those pajamas. What was I supposed to wear? When patients are in that hospital, yes, it praised me, but I absorbed those. The part that destroyed me was when it said the minister is intent on promoting public health, that he's prepared to risk his own eyesight. It was written in black and white, yes, that I'm risking my own eyesight by going to be treated where people are treated, because I'm supposed to be a different type of person. Surely, we can't want to run that type of a healthcare system in our country. And that's why you need to help us to innovate and come up with a new architect of the healthcare system of our country. Thank you very much.
Thank you very much to the Honorable Minister for the engagement. I think the time is now for us to start interrogating some of what the Minister was saying. And I must say, Minister, we agree on the primary health care. And I had thought at some point that we have lost the path, because I remember the green paper, I think it was on page 3 of the green and 4 of the white paper. We were saying that the primary health care will be the cornerstone of the NHI. That's what we used to quote. But I think we somehow lost our way and we kind of took a narrow approach to focus on finances. And I don't know, I might be wrong, but I don't think finance, we are not poor in South Africa. I can tell you for free. I don't think finances are our fundamental problem in healthcare. I don't think so. And the minister will agree with me because in his first term in office, he commissioned a high-level team to go and look into the health sector to find out what was the problem. And they came back, they told him that it was leadership and governance. Every time, I'm sure he doesn't really enjoy this, every time I meet with him, I tell him that in my previous life, I earned quite a lot running an academic hospital, but the CEO I was reporting to is the delegation of authority to actually fix a broken window was far less than what we were earning. So why were we there? He knows that leadership and governance is a fundamental issue. Because if you are paying somebody about over 2 million rands and their delegation of authority is far less than that, why are you paying them for the whole year? That amount of money, at least match what we are already spending. So it's going to be interesting, Minister. I don't have questions today. I'm going to allow the audience to deliver questions to the Minister. Do we have someone who's got a mic down there that is running? Thank you, Vezi. Thank you. Okay. Can we see the show of hands, colleagues, for the question? There's a lady here in front, ma'am. Oh, okay. Reggie, I'm going to need you here.
The answer is you can use these mics. Yeah. Your mic, use that one.
Okay, sanibona. Sawubona Minister, ngiyaxolisa ukustatha the way around. Igama lami ngu-Ayanda wakaNciki. I'm from Enkandla. That is my birthplace. I just want to start with thank you for being exemplary. I would want to remind you when you went to Charlotte Maxeke for your operation. This is just not a new thing that you really want us to give the best, because that's where we're going to be treated. If you have a stroke, you work in a public sector, we're not going to wait to thrombolize you in a public hospital. You need to provide the services that will be able to manage the stroke acutely, because we know we've got a window. So if we provide services that we are scared of as professionals, which means we will run into trouble, it will backfire to us. As a rural child, I am so humbled here. I have a lot of professors that have taught me to become the specialist I am today. Sorry, emotional kancane. But one thing they have taught me is courage and to go back to the areas to provide the support. And that's where I'm coming in to talk about innovation and elevation. Innovation without a certain aspect catering for the rural areas is going to be non-existent. because you will always be running with runners at the forefront and people who are walking. You will never have a team and you'll never be successful. So we would like to ask Minister to also not forget breast cancer. Breast cancer is under CA cervix, but the burden and the death is related to breast cancer compared to CA cervix, meaning that it is very important to remember innovation and transformation and technology when dealing with breast cancer. Yeah, that's
Okay,
that's all.
thank you very much. I now regret having asked Reggie to do this because I don't know how you would manage the questions. Can they be straight and to the point, colleagues, so that we can allow as many as possible? Tepi, I'm going to ask the hands to come back up. I know Koza and Kaneme. Let's have Tepi.
Oh, sorry. Good morning, Minister. Thank you very much for your insightful talk. My name is Tepile Tladi. I am a newly qualified pathologist. I truly appreciated your talk, and I just wanted to talk regarding the HPV prevention and HIV prevention. In as much as it's a great innovation, I am still heavily concerned by the sexual behavior or sexual practices in South Africa. And I want to emphasize strongly that the Department of Health still needs to emphasize that we practice safe sex in South Africa. The number of cases of syphilis I've seen in my own practice over the last 2 years has been far alarming. And I know it's associated with the lower production of benzyl penicillin. So yeah, I just want to emphasize that in as much as we are improving and preventing HIV, we're preventing HPV-related conditions, in effect, we still need to consider the fact that there are still other conditions or things that burden the state regarding sexual practices. Thank you.
Thank you, Tepi. Let's go to the gentleman behind you, Tebza. I'm coming to you, Ruben and Koza.
Hi, I'm Jared. Firstly, I'd like to thank you for your speech. My question is relating to primary healthcare. Of course, it is going to be the pillar of our national health insurance. But my question relates to the ideal clinic concept, which is an international set standard, and I'm concerned about the applicability of it in South Africa, specifically relating to trauma cases. In primary healthcare, we see a lot of major trauma events, and this isn't really accounted for in the ideal clinic setting. So are there plans to adjust the ideal clinic the ideal clinic checklist to further include trauma cases?
All right, we have to accommodate the minister's ability to respond to this question. So I will take two more and stop. Koza, then Rubin from Namibia. We're coming to you, ma'am. We're coming, but let's allow Dr. Koza here and Dr. Rubin Kanime there in front. Okay.
Thank you. I'm Courage Koza, public health specialist from Mpumalanga. Thank you, Minister, for your speech. I want to ask about the declining total fertility rate in South Africa. Our fertility rate is around 2.2, replacement it's 2.1, and the East Asian countries, they are now below 2, so they have too many people for the present, but not enough for the future, and we are going there as a country, and that 2.2 includes a lot of non-South African. If you work in our facilities, you'll know that there's a high rate of people that are delivering from other countries. So I want to check as to what are the current conversation in terms of the future population of South Africa. Because our deliveries are declining. We've got a lot of targets to say we must vaccinate this number of kids, we must do this and this. But in some of the facilities, they say we've gone out to the schools, we've gone out, we don't find the kids. And we were using the population of last year. The deliveries of this year are always lower than last year. And it's going down at a far greater rate than what we're expecting. So my concern is that in maybe 50 years' time, our population will be so low that we don't have enough people. So where are we in terms of thinking about that? And that also affects maternal health issues, because now we have primigravidas that are in their 30s, mid-30s, so that is also an issue. Last question is about how do we actually build hospitals in terms of the planning phase? I've seen hospitals that were built without meeting certain requirements. Mental health regulations talk about a certain wing of the ward that must meet certain regulations for a 72-hour observations. I've seen some of the new hospitals, they don't meet those new regulations. So I want to ask, how do we actually plan when we build a new hospital? Thank you.
Okay. Ruben, please be brief, my brother, so that we can accommodate 2 more questions. Let's give Ruben there. Please be brief. The minister needs to be out here in a few minutes. So Ruben and then the lady there. Yes.
All right, thank you, Ruben from Namibia. Honorable Minister, if I didn't misquote you, I think you said innovation without participation is a crime. I represent Coalition of African Medical Association in SADC. And I know the SADC Committee on Health of Ministers. What is your take on collaboration between the Coalition of African Medical Association in SADC with the SADC Committee on Health? Is there a room? Thank you.
Thank you, Ruben.
What is your take on collaboration between the SADC Committee on Health and the Coalition of African Medical Association in SADC? Because there's a general feeling that sometimes we are excluded in policy formulation and development as healthcare professionals, and we want to be active participants. Do you see a possibility of us collaborating? Thank you.
Did you get that one? Okay. Then that's the last question, colleagues. There, ma'am, that's the last question, Minister. Sorry, so that we can just respond to all of them.
Good morning, and thank you, Minister, for the speech that you have given. My name is Lungileka Sapato. I am the CEO of PPO Serve, a health management company that organizes GPs at a primary healthcare level to work in multidisciplinary teams, pay them a global fee, a capitation fee that is risk-adjusted, and give them outcomes that they have to achieve, and when they achieve them, pay them a sort of a bonus fee. And we do that to strengthen primary health care with the view of reducing hospitalizations downstream. Now, I was very encouraged to hear you talk about or referring to the health market inquiry, which we built our organization based on all the findings that were found there. However, it's been very frustrating for us to observe that nothing has come out of that inquiry. And I heard you saying that you are now having regulations that are going to be coming out and are going to be rolled out. What I want to find out is there any way that you as the government or the ministry can assess and influence not only the public sector but also the private sector in terms of the funding? And I'm talking about the schemes. We have seen the costs rising to the point where a lot of people cannot afford anymore. But unless we address these structural issues that contribute to the cost rising up, we will never see any improvement. And currently we can see in the media, there is a lot of outrage because people are feeling that they're being pushed out. But I feel that there could be more that can be done, especially from regulatory, where we can encourage funders to purchase strategically as guided by the WHO in order to ensure that patients are getting the value and therefore the cost or the rising costs are abated. Thank you.
Thank you very much, Minister. Over to you.
Yeah, no, I can come back. Yeah. No, thank you very much. The questions that have been asked here need a special conference, unfortunately, because they are very involving and deep. And thank you very much for that. Dr. Nodikita, I think we need to think much deeper and be very careful because You are in a profession, you and me, in a profession where if you can't diagnose a problem, you're going to give a wrong treatment. You know that. And if we miss the diagnosis of the problem we're faced with, and I know arriving at the diagnosis can at times cause altercation between doctors. I don't know whether this is still there at medical school, Professor Ames, the grand round. Yes. We used to have something called the grand round where all the big brains come together to come and discuss a particular patient. Big brains from all the others, and you'll see who is who there. I remember GPs from Lazi, Lamontville, Claremont, they used to close their practices when it's come for the grand round to come and listen there, because they are arguing about the diagnosis. And sometimes they never reach a conclusion, or they live there pointing fingers at each other. So not getting a correct diagnosis. Now, doctor, this issue of healthcare financing, I don't want us to underplay it and put only leadership and governance at the fore. The World Health Organization was very clear that a healthcare system anywhere in the world is built of 6 pillars. And all the pillars need to be equally strong. There are 6. It's not 1, there are 6. And the first one is leadership and governance that you spoke about. It is there, but it's one of the pillars. Believe you me, it won't keep the building up alone. It won't support the building, the healthcare system alone. Leadership and governance. Can you imagine having one of the best leaders in a hospital who doesn't have a budget? Yes, who doesn't have a budget or doesn't have adequate budget, etc. So leadership and governance is important. But also the second one is the availability of commodities, medicines and other health commodities, including infrastructure. And the third one, which was discussed very thoroughly in Geneva, is the health workforce. I know some raise it all the time. The bad news is that it was revealed that in 2030, the very year in which we're supposed to reach our sustainable development goals, the world will be short of 11 million health professionals. It has already been projected. That will be short of 11 million healthcare professionals around the whole world. That is scary. It needs leaders to put their heads together. So the issue of health workforce is important. But the fourth one is healthcare financing. It's healthcare financing. And the fifth one is what I briefed you about, the health information system. Do you have a good healthcare information system? And the last one is healthcare packages, the packages through which the population receives healthcare. When a woman is pregnant, what can they expect? In South Africa, we know only women with a medical aid know what to expect and what to get. They know that they are going to be put under, they are going to be put under a sauna, a scan. Yeah. And of course, in the present health architect, they are put under a scan to see the sex of the baby and pay lots of money. We all know that it has got no meaning in healthcare to know the sex of the baby before the baby is born. When you don't know what the head looks like, whether, but that's how we use these innovations wrongly, because innovations can go very wrong. Yes. Then that's the last one. Now, the issue of healthcare financing system. You see, Dr. Notikita, I agree with you on one part, but when we move further, we start differing. I agree with you that in South Africa, our problem is not the money. And it's a very difficult thing to say. Why am I saying so? Because the World Health Organization said countries must spend at least 5% of their GDP on health. And it has been calculated that if any country pays 5% of their GDP on health, it's likely to reach the rest of the population. In South Africa, we have long exceeded that. That's why I agree with you. We have long passed 5%. We are at 8.5%. If you don't know what it means, we have even overtaken highly developed countries like Russia. Russia is not at our level in terms of expenditure. They are still at 7.8%. China, the second biggest economy in the world, is still at 6.8%. India, the biggest population in the world, is not even yet at 5%. They are still at 3.2%. We are at 8.5%. Why am I mentioning those countries? They are within BRICS, and all of them have got much, much better health outcomes than South Africa. They have. Even India, which has not arrived there. Because the problem, Dr. Nodikita, is not the money, as you are saying, it's the way the money is distributed. That is where the problem of South Africa is. And how is it distributed? 51% of that money goes to only 14% of the population. No other countries like that in the whole world. Where 14% of the population is responsible for 51% of the expenditure, leaving 86% of the population to remain depending on who you ask, people who don't like that, who don't like equity, will tell you, no, the problem is corruption. I'm not going to say no, because corruption is there. And every day, they quote Tembisa Hospital, as if Tembisa Hospital is part of our plan. They are even saying we can't have NHI because of what happened in Tembisa, punishing the masses twice. In other words, telling the masses, some scoundrels stole money, your money from a hospital, then you can't get universal health coverage. We can't even talk about it. It's wrong. Corruption needs to be fought. We were not part of the people who stole money there and went to buy Lamborghinis. We want them charged, and we want that money to be brought back. That's why we are working with SIU to bring it back. And I'm sure you are aware, there is one who already got cold feet. Even before the trial started, he brought back 13 million rand stolen from Tembisa. A very junior official. I was even telling them, I'm very, very jealous and angry. Because I've been working for 42 years now. Even if you were to put a gun here and say I must take back 13 million rand, I don't have it. After working for 42 years, here is a junior person, you know. So I'm angry. We want that money back. The people who stole that money have got houses. Yes, we want those houses to be followed up by the SIU. They've got pensions, and the pensions are kept by the state. You know, so the issues of corruption we must deal with and not use them as the reason why we must stop universal health coverage. We mustn't. Even in the private sector, they tell us there's corruption to the tune of 28 billion rand, but it's not called corruption because it's not in the public sector. It's called leakage, wastage, and all that. Corruption is, it's called in those names. And Dr. Nodikita, I asked them, why punish black GPs? Do you know in this medical scheme system, GPs in South Africa get only 5% of the slice? And count how many of them. You are even getting less than what is called non-health people. People who are pushing paper in offices. GPs are getting less than them. But when they were fighting this so-called leakage, which I know is corruption, they went for the GP. I even asked a question under Section 59. How do you chase people who are responsible for only 5%? Even if you get all of it, it will change nothing because that's not where the money is. So the issue, when we call G20 and say solidarity, equity, and sustainability, we're not joking. We demand that equity. That's why earlier on I said the central pillar of NHI is what you call primary health care and healthcare equity. It's not equitable, by the way. And who are the people who are gaining from this inequitable healthcare system? It's all of us who have got titles and names in South Africa. Anybody with no title, with no name, is not entitled to good health care. That's why I'm praising Namibia. Because there it means whether you have got a title or what, you must get the same treatment that others are getting. That's the best thing that a country can ever do to its people. So congratulations to our President. Tell her to come and preach to the whole region, to the whole African continent. So I just want to emphasize the issue of healthcare financing is a homework that we must all face. If we don't do so, yes, there are going to be uprisings about it. Because somebody here told me, yeah, you said they are not coping. It's true. It is true. I was summoned, myself, the Minister of Health, and the Minister of Labor and Employment, were summoned 3 weeks ago to NETLEC. NETLEC in South Africa is a policy unit where the state, labor, business, and community meets. Those four structures. They summoned us. Why? Because one of the big trade union federations in South Africa, FEDUSA, has lodged a Section 77 complaint. A Section 77 in NETLEC is where you are asking for permission to go on a labor action, including a strike without being punished. Well, except no work, no pay. That one is standard. But without being fired. So they had to ask for that permission. We were asked what our position is. Now, they were complaining that the medical scheme which public servants belong to, GEMS, has increased their premiums by 9.5%, as you know. I know we receive letters that it has been decreased to 7.2. That means nothing, as far as I'm concerned. Yes, and it was put to us as an achievement. It's not. But in the meeting, I said, I agree with FEDUSA as a minister. Because I don't know any minister of health anywhere in the world who wants health care to be too costly for the population. Then you are not a minister. All ministers of health I know of worth their name and their soul want health care that is affordable to the population, even to the lowest person. We all want that. So I told them that I agree with FEDUSA in that regard. But then I said I sympathize with GEMS. Why? Because GEMS raised these fees because of what they are being charged. That's what I earlier on said, the cost of healthcare. It needs to be fixed. And in the meeting, GEMS defended themselves. They said, no, let's tell you why we raised these premiums by 9.5%. We collected 95 billion rand from members of GEMS who are public servants. They said we collected 95 billion rand in the past year. But the total money which we paid for their health care is 97 billion, which means we are in the red. And what can we do but to increase? That is still going to happen unless we fix these issues that I've spoken about. So it is true that workers are already agitating because they can no longer afford the system. I try to take a shortcut, but maybe I need to explain to you what we mean when we are about how we are going to fix this healthcare cost. Before 2006, it was not like this. There used to be a structure called REMS, Registered Medical Scheme Administrators. They used to give practice numbers. Now, that work is done by BHF, Board of Healthcare Funders. But they also used to bring all the stakeholders around the table to negotiate prices. The specialists, the private hospitals, the GPs, the medical aid schemes, everybody involved in healthcare used to come around the table to negotiate prices. Of course, they will not make the prices better, what we want. They wouldn't, but at least they were able to contain them. At that time, when I was a GP, they used to give us a file. After the price negotiation, they send you a new page which indicate the prices. From the price of Panado to to the price of doing brain surgery. They were all there. And they tell you this is this much, this is that much. Now, in 2006, the Competition Commission in South Africa came to abolish that because they said this is price fixing. You know how Competition Commission work in South Africa. We went to them to challenge them when the expenses were now going higher and higher and higher. And they said, no, we won't allow price fixing. And we argued to them when we discovered that in a way they were right. During the negotiations for prices, medical schemes did not have capacity to negotiate. They were sending administrators. The administrators of medical scheme, who are a separate entity, they were going there to negotiate on the basis of medical schemes. But then there was a contradiction. If providers charge more, the medical scheme administrators get more money than if they charge less. But they must go and negotiate lesser prices, meaning they must negotiate themselves out. So in the negotiations, they were happy with higher prices. That's where Competition Commission moved in. So I went to Competition Commission, I said, please, I know what we're trying to do, but it has destroyed private healthcare in South Africa by making it extremely expensive. Can you reverse your decision? They said no. That was in 2011. In 2014, after I pestered them, I never stopped. After I pestered them, they said, look, you are giving us anecdotes. Can we get scientific evidence that indeed private healthcare is very expensive? I said, how? They said, we are going to put up a health market inquiry. That's how the health market inquiry was born, to come and prove. And we gave them, together with the Competition Commission, we gave former Chief Justice Mngcobo 6 months to finish us that work. 6 months. Do you know how much it took? 5 years. Because everybody was going. Even outside bodies from Europe were coming in. You know, some of the detractors who want healthcare to be expensive, they went to the US because they believe the whole world is owned by US. They went to the US to get what they call health economists, to come and prove to us that what is expensive is not expensive. They were coming to convince us that in terms of rule, what, this is not expensive. Now, we went to the World Health Organization to take the professor, the doctor who was in charge of healthcare financing, Dr. Joseph Kutsin, who coincidentally is an American. And I was sitting there puzzled. 2 groups of Americans coming to South Africa to come and argue against each other for us while we were sitting there and watching. I was not very comfortable with that. Yes, but the issue here was the health market inquiry eventually proved. That's why they gave recommendations. One of them that we must regulate the price of healthcare. I agree with you that nothing has happened because behind closed doors, I told you, there were a lot of legal headwinds. We believe we have resolved them, and something is going to happen. There's no way we can go on with this unregulated pricing of healthcare. It simply is not on. It won't survive. That we know as a fact. It does not matter what happens. The people who were celebrating and misleading the nation that the certificate of needs is a central pillar of NHI and it has been collapsed. It might be that eventually the judges ruled against NHI, we don't know. At the moment, nobody knows. That ruling is still coming, but the celebration is now. Because of CEO, it reminds me of Bafana. Yeah, they are going to the World Cup, they went to Africa Cup of Nations, eventually. But there was a time when they celebrated a win in Mpumalanga in front of the whole world. They celebrated a win that did not exist, if you remember that. So we don't know, they might still win because we don't know what judges will say. But to come and link things that are not linked now is something that, I don't know, maybe it's a South African thing. Ayanda, we can't forget breast cancer. The thing is, I was talking about primary health care and eliminating a cancer. We don't have mechanism here to eliminate breast cancer. We only have mechanism to treat it. Very expensive mechanism, I'm sure you are aware. I'm adding very expensive. Maybe I must add another very, very, very expensive, which ordinary women who suffer breast cancer, they won't be able to afford. So the reason that I left it is number one killer. Cervical cancer is number two, but we've got a method to eliminate it. So why can't we do so in our primary health care systems? Dr. Tladi, sexual practices in South Africa, that there's no safe sex. You are very right. Coincidentally, when I was in Geneva, because we met the Global Fund, they are the ones who gave us the first doses of this lenacapavir for $29 million. That's why we are launching lenacapavir. So we're sitting with them in Geneva this week. Remember, I arrived back yesterday. We're sitting with them to talk about this. It's not a problem in South Africa, it's all over the world. When we introduce lenacapavir, what's going to happen? I've already heard, men have already approached us to tell us so. We have got 4 groups of people who are going to prioritize for lenacapavir. One is adolescent girls and young women up to the age of 24. 2 is pregnant women and lactating women to stop mother-to-child transmission. 3, female sex workers. 4, injecting drug users, men having sex with men, and transgender people. So those are the 4 groups. But we were told, we are launching South Africa on the 5th. Other countries have already launched. So they were sharing with us in Geneva that the people who are coming to take lenacapavir are not those who have identified. It is men who don't want to use condoms anymore, unfortunately. And even here, they've already asked us, I get phone calls, hey man, injection you know. Why do you want it now? I said, no man, we want freedom from condoms. It's condom slavery. Minister, no man, hey, these things. So in Geneva, this is what we said. It might not be a correct decision. We said the biggest problem Africa is faced with is HIV and AIDS at the moment. In South Africa, we are spending 46.8 billion rand every year to fight this disease. That's money we can use to employ more doctors, build more hospitals, etc. So if we have got an opportunity of stopping it, let's do so. So we said these others, Dr. Tladi, which I call side effects, let's live with them for now. I know what you are meaning. Syphilis is going high, gonorrhea is going high, etc. Even pregnancy, I'm sure. If people are not using condoms, but believe you me, men are determined not to use condoms. It's something that breaks my heart, but what can we say? You know, we are going to encourage them and teach them that lenacapavir only stops HIV. It doesn't stop sexually transmitted disease. It doesn't stop pregnancy. Please use condoms. But they've already made it clear, as they phone us, that we want freedom. I don't know what type of freedom is that. That men were in slavery. I don't know, but it's a problem that we are faced with. And the other 21 countries that have already launched, they reported to us that that's what they are experiencing. They are experiencing men coming in rather than these people who have targeted. We targeted the young girls because HIV/AIDS in South Africa is growing through them. When we say HIV/AIDS, every year we get 150 new infections. It's mostly young girls. And we thought if we target them, we'll break the back of HIV. We'll see what happens. The establishing of PhD in trauma cases. Look, let me explain. People believe primary health care is a poor cousin of curative health care. That's the mentality that we have. Because they believe primary health care means when you go to a clinic rather than an academic hospital. Primary health care means prevention of diseases and promotion of health. And when you are sick, you start at the bottom, not at the top. And at the bottom, that's where clinics and GPs are. We want to use clinics and GPs as the first port of call. So trauma is also involved in that. But colleagues, primary health care can solve lots of problems. When we introduced the pneumococcal vaccine, maybe many of you don't know, we introduced the pneumococcal vaccine and the rotavirus about 15 years ago. When we introduced it, it cut off, I suspect pediatricians here know, it cut off admission to hospital, admission from pneumonia, it cut it off by 70%. Meaning young kids who will have gone and be admitted in hospital with pneumonia, they could no longer go because of the pneumococcal vaccine. That is what we mean by primary health care. I usually tell members of parliament that I'm very jittery when they question me, when are you building more dialysis units? When you dialyze somebody, it means you have already failed, remember? Yes, it's already a sign of failure, but they say we must put more. What do we do in primary health care? Salt, excess use of salt. That leads to high blood pressure, kidney damage. That's where you must start with primary health care. Putting up as many dialysis units as possible. How does it help the population? How does it reverse the problem in the population? Courage causes fertility. Yeah. When I did gynae for the first time in medicine, the professor who came to teach us family planning, at the infertility clinic, he said there is a bit of a contradiction here. Because we open infertility clinics alongside family planning clinics. We stop others from delivering, but others want them to deliver. And he asked us, which one is better? We couldn't answer that. He said, no, each individual who is choosing the one that suits them is better for them. If I want go to a fertility clinic because I can't deliver a baby, my needs are the same as the woman who wants family planning. It's unfortunate. So I am aware that population development goes hand in hand with lowering of fertility. That's the problem that Europe is faced with. So which one do you choose? Under development so that the fertility remains high? We can't do that. We just have to see how we deal with this problem. The fact remains when people develop, they no longer keep many babies. It's a fact. Many modern day women cannot be like, in my family, we were 12, by the way, if you don't know. Yes, I used to say we are a football team plus a reserve. We can challenge Bafana. But yes, that can no longer happen. I don't expect my wife to go through that, if you understand what I mean. Yes, so when you develop further, some of these things change and population changes. And Europe, I am aware, is suffering that. It's getting very elderly people who are in their 80s, but there are no young kids to replace them. It's because of their level of development. The 72 hours for mental health, you are right. When the World Organization called a conference about mental health some years back, one of the things they indicated is that in every country, mental health comes at the back. You budget for everything, whatever is left, you throw it at mental health. We are doing a similar thing. That's why among the hospitals we are going to build, which I told you about the 3 big ones, is also a mental health hospital in Mpumalanga. Mpumalanga doesn't have a single mental health hospital. Not a single one, it's not there. They all refer to Gauteng, overburdening it. So it just shows how we've been planning for mental health, but we need to get out of that. The comrade from Namibia, I didn't take your name very well. So, yeah, forgive me for referring you to that. The chairperson of the coalition. South Africa is chairing SADC now, after Madagascar had problems. We're supposed to take it in November, but we took it before. So I'm chairing the ministers. I'll raise that issue because you are shaming me. That we are trying to run, as SADC ministers who are trying to run the healthcare system without professionals is wrong. I'm going to raise it with them in the next meeting. I'll raise it, maybe we'll even make sure that we invite you to that SADC meeting to come and put your story. I'm sorry to say that without consulting my colleagues, but I hope they won't kill me. To have a colleague who is coming to present. Thank you very much.
Which one? Colleagues, please join me, and we appreciate the minister for coming. We know that his schedule is very tight, but he made time for us. Please, let's give a round of applause for the minister. Thank you. Oh, okay. Oh.
So she took.
Yeah, she took. Are you done? Okay.
Yes, tell me how much is it, then I'll declare.
Okay.
Thank you.
Okay, thank you.
Thank you.
Ladies and gentlemen, I believe that has brought us to the end of our morning session. It has been quite a push, I believe so. And there's a lot of responsibilities onto me to finish the rest. But shall we please all just rise for the minister so that he may be ushered out by the SAMA leadership? Thank you very much. While I have you guys standing, let me please give you the next announcements. There will clearly be a change of program, as you guys can see. We are almost about 2 hours behind schedule, but we will sort it out. Do not stress. So it's 11:30 according to my watch, about 11:32, 33. So can we please all be seated back in the hall by 12 o'clock? That gives us about roughly 28 minutes to go and have tea and also to interact with our exhibitors and our sponsors. 12 o'clock, please do not be leaving the tea area. 12 o'clock, please be seated back in the main hall. Thank you so much. Enjoy tea.